Hi, I'm Dr. Lee Rogers. I am the president of the American Board of Podiatric Medicine, and I'm honored to be able to give this talk today for the Diabetic Foot Summit. I am going to be speaking on the Charcot foot, a report from the International Task Force. So again, Dr. Lee Rogers, President, American Board of Podiatric Medicine, also associate editor for the Journal of the American Podiatric Medical Association. I am actually just starting my position as chief of podiatry at the University of Texas Health Science Center in San Antonio. So a little history on Jean Man, the French physician who this condition is named after. And he originally described this in the knee of a patient with tabetic arthropathy. That's what he called it, tabetic arthropathy, from tabes dorsalis. And after he presented a group of arthropathies related to syphilis and tabes dorsalis at the International Medical Conference in London in 1881, those at the conference decided to bestow upon this condition his name and call it Charcot's joint, or Charcot arthropathy, and now we call it Charcot foot. But I will say that in one of his later papers on tabetic arthropathy, I found this very interesting, in that he ends his paper with this phrase in French, "Sera continuée," which means to be continued. And I would argue that, here it is over 150 years later, and we still have a lot to learn about the Charcot foot, and the information I'm giving you today is Sera continuée. So the International Joint Task Force was convened, I think we started somewhere around 2009. We met in Paris in 2010 and then later published the consensus document called The Charcot Foot and Diabetes in 2011. And that document was jointly published by the American Diabetes Association and the American Podiatric Medical Association in both organizations' respective journals. And we're actually working on an update to this as we speak. COVID delayed us a little bit, but we anticipate that being out sometime next year. So given that this lecture is a report on the task force findings, and that task force is a little over 10 years old now, and that we're putting together new papers for the new task force, I have intermingled some of the new things into this this lecture. So you'll see some things that predate the task force and actually, contain the task force opinions, and then some things that are my own opinions that have come out since that time, since we're reorganizing this now. The International Task Force met at the La Salpêtrière Hospital, which is where Dr. Charcot, where he originally practiced. And we completed the manuscript even there in that room. We did have the opportunity to look over some of Professor Charcot's original works, including some even pre-printed notes that he had created. And you can see here, this is a pre-printed note from a press in which Charcot wrote on this his exam findings with his patient. And over there on the left, that's my co-chairs, Dr. Bob Freiberg and Dr. Dane Wukic. So when we think about what is the precursor to Charcot foot, the answer is really any condition that can cause peripheral neuropathy. However, in the Western world, and predominantly now around the world, it is peripheral neuropathy secondary to diabetes. that is the predominant disease leading to Charcot arthropathy. We know that the Charcot foot risks that there's a 36 times increased risk for a foot ulceration when you have Charcot. There's a 30% incidence of bilateral disease. Doesn't always occur at the same time. In fact, usually what happens is that a patient with Charcot will have some type of treatment and offloading or favor the foot that is injured, and then add more stress onto the contralateral foot, which all the factors that led to Charcot were present in both feet, and now we have a new injury sparking that bilateral disease. Now, there's also a high incidence of amputation secondary to Charcot, in some studies upwards of 15%. That's not where all the risks end. In fact, Charcot patients have a higher rate of coronary artery disease and coronary plaques when compared with diabetic peripheral neuropathy patients. It was interesting in both of these studies, it looked at whether or not these plaques were calcified. And if you understand some of the pathophysiology of Charcot foot, in which the bones are essentially being demineralized or softened, and locally you do sometimes see calcification of the vessels. But what these two authors found was that when you look at the calcium scores were no different between the groups, but there was a significant difference in the arteries that had atherosclerotic plaques. So those with Charcot foot and concomitant coronary artery disease have a higher incidence of death. And if you look just at the mortality alone, the risk is 2.7 times greater for those with Charcot versus a matched cohort, which has diabetes, neuropathy, other comorbidities, except Charcot. So in fact, there is an increase in the mortality from Charcot itself. The quality of life, Charcot foot and ankle deformities dramatically impact negatively on the lifestyle of affected individuals. This leads frequently to permanent disability and premature retirement. So when we look at the pathogenesis, really there's, let's first look over here on the right. There is the French theory and the German theory. The French theory is one of a neurovascular theory where the Charcot himself proposed this theory, or he proposed more of a neurotrophic theory, but later evolved into the neurovascular theory, where the nerves, the autonomic neuropathy, the neuropathy is causing also autonomic neuropathy, leading to an increase in the blood flow of the locally in the foot, leading to a washing out of the minerals in the bones and softening, and then that leads to fractures and dislocations. Now, Virchow coined the German theory, which was a neurotraumatic theory, and he thought that this was due mostly to the trauma that was occurring in the foot that was repetitive and unfelt because of neuropathy. And that trauma caused a lot of inflammation, which then led to washing out of the bones and demineralization and fractures and dislocations. And in reality, now we kind of see both of these things working together, and we have unified this theory, and this is really the modern day understanding of the pathogenesis. Now, this pathogenesis is one that's kind of a circular process. We start out with diabetic neuropathy with resultant hyperemia. There's an exaggeration in blood flow locally in the foot. This can sometimes be from minor trauma. It can be from a foot ulcer. It can also be from some type of surgery unrelated to Charcot, just having a bunion operated on, or even a revascularization is enough to spark this. And then we see that there's fractures or dislocations. These are often painless, and patients are continuing to walk on it, which continues the insult, and it just goes around in this vicious circle of inflammation and deformity. Ankle equinus itself is a major problem, and also part of the pathogenesis of most presentations of Charcot foot. And what you see here is that because of the intrinsic tendinopathy, which is prevalent in patients with diabetes, there's actually changes to the characteristic of the tendon, less elasticity. Also, there's, because of neuropathy in the and the difference between the anterior and posterior muscle groups in the leg, you have an overpowering of the posterior muscle groups, which is pulling tighter on the Achilles tendon. And that pull of the Achilles tendon, you can see here on the left, is declining. It's causing a declination of the pitch of the talus and the calcaneus together. And so those are being plantar flexed now. And then the resultant trauma that usually occurs is at the midfoot, where you see a deforming force that occurs at the midfoot. And that's why the Achilles tendon is addressed many times during surgical reconstruction of the foot. So we must have, in the diagnostic approach, a very high index of suspicion. This is probably the most important thing about the diagnosis of Charcot foot, is suspecting it in anyone with a red, hot, swollen foot in the presence of diabetes and neuropathy. And we should think about this as Charcot foot until proven otherwise. This is a medical emergency. Medical emergencies are defined as a medical condition where there is a therapy available that can transform its natural history. And if you think about the possible outcome from a Charcot foot, ulceration, infection, amputation, death, hospitalization, surgery, all of these things, this is a dire and true medical emergency that requires immediate treatment, because the immediate treatment will alter the natural history of this disease and can prevent all of those things. Not to mention that when I go through these treatments with you, you'll see that the treatment itself, that's probably the most appropriate during this emergent phase, when maybe you don't even know what the diagnosis is yet, or you're just suspecting Charcot foot, is something that's pretty low risk, offloading, and should just be done while we're waiting for the confirmation of the diagnosis. We often use thermometry to measure the temperature and determine the inflammatory response of the foot. Now, how we do this is we look and see if there's an asymmetric skin temperature increase. And what we're looking for is, most often in the Charcot foot, it's the entire foot that's hot and swollen. Sometimes we're studying this for diabetic foot ulcers and we're studying certain points, but you check the same point on each foot. And if there is a difference of 4 degrees Fahrenheit or around 2.5 degrees Celsius or greater, then that's significant for inflammation occurring on the hotter side. And we can also use temperature to monitor the response to therapy. Now, fast forward, here we are, it's 2021. And actually, this is even an older camera. This is one of my early cameras. This is a thermal imager that I had about 10 years ago. And now I have one that just attaches to my phone. But you can buy these thermal imagers that attach to your phone. And we see that there's a drastic increase in the temperature of the Charcot foot here. There's 10 degree difference Fahrenheit. I think that's about 6 degrees Celsius or so. And so that's significant for inflammation and Charcot foot. And we see, pretty much the whole midfoot around the joint, but the entire foot is hotter than the contralateral foot. That's also a good depiction. I'll just go back this for a second. This is a great teaching tool for your patients to show them things that you can't see. Now, you might be able to feel it, and certainly a 10 degree difference you can feel by palpation, but there have been studies looking at what the temperature difference has to be to actually palpate a difference. And that's somewhere around 4 degrees to 6 degrees for most docs to be able to palpate a difference. So this is something that not only gives you an objective measure, but then also you can show your patient and they'll learn from this and see when they're doing the right thing and offloading and how the temperature's coming down. And again, it's not the actual temperature, it's the difference between the two extremities. So even if the actual temperature goes up, the next time you see the patient, we're just looking at the difference. That's all we care about. Now, once we've made this clinical diagnosis, we have this high index of suspicion, we need to confirm our diagnosis with imaging. And X-rays are the most useful. I cannot underemphasize that. We need to do X-rays early, and actually X-rays even often if they come back negative. So early on, there may be no findings or only subtle findings on an X-ray that you really have to be an expert in order to see. If you obtain weight-bearing foot X-rays and you get comparisons either from previous films from the same foot or get a comparator that same day of the contralateral foot, this can help to accentuate any small or subtle differences between the feet and make you more suspicious of Charcot foot. So when we see the classic rocker bottom deformity, that's actually a late finding in Charcot foot. So the most important angles that we look at are the talo-first metatarsal line and the calcaneal inclination angle on a weight-bearing lateral. And both of these can predict ulceration. But if the X-ray is negative, then we move on to more advanced imaging. So when we look at the typical X-ray findings, especially these two angles on the lateral X-ray, what you see up in A is a patient that presented for a hot, swollen foot, and the X-rays were essentially normal. And I've outlined the first metatarsal, I've outlined the talus for you in dotted lines, and you can see that the lines are unbroken, and that's what we call this talo-first metatarsal angle. If we connected those two lines, it would pretty much connect. In that case, you bisect the talus, you bisect the first metatarsal, and that's normal. Now, 1 month later, this patient only saw us a month later before he saw another. I think this was actually in the emergency department, but saw us 1 month later, and we were able to compare to the earlier X-rays, and we saw how the earlier X-rays were normal. But even in that case, we should have offloaded this patient because the clinical suspicion should have been high in a patient with a hot, swollen foot with diabetic neuropathy, and the patient should have had further imaging to confirm, like an MRI, which I'll get into in a second. But what we see after 1 month only 1 month of unprotected weight bearing, we see a total destruction now of the midfoot there at the white arrow. The talo-first metatarsal angles are broken. And so they're not connected any longer. The talus is declined, pointed now down towards the ground, and the calcaneal inclination angle has also greatly reduced. These are all classic signs of Charcot deformity on an X-ray. So the MRI is actually the most sensitive and specific for Charcot foot. There are early findings that are clear on MRI, like marrow edema, trabecular fractures, periarticular soft tissue injuries. But the MRI does have difficulty distinguishing Charcot foot from osteomyelitis if you're just looking at the MRI itself. However, if you use secondary signs, you keep the part of the understanding of the difference between Charcot and osteomyelitis, not even the clinical understanding, but not looking at the patient, but still just looking at the MRI, you can help to see which one is more likely. And I'll give you an example here. So Charcot foot predominates in the midfoot. It affects multiple joints or bones, and deformity is very common. Osteomyelitis predominates in the forefoot and or the rear foot. It generally only affects one bone. If you see many bones that are lit up on an MRI, you better be thinking Charcot. And also, deformity is very rare with osteomyelitis. So if there's deformity present, you also should be thinking Charcot. And oftentimes, there is direct extension visible from an ulcer to a bone where there is osteomyelitis. In over 90% of cases, you can find that. And so if there is no ulcer, then again, we think mostly Charcot in this case. Now, if there is an ulcer, you could have osteomyelitis and Charcot together as a combination. So more difficult to differentiate. There are several classifications that exist for the Charcot foot. Some of them are radiographic, some are only anatomic, describing which joint is involved. The International Task Force recommended a very simple classification of just active or inactive, because that really determines what kind of treatment you might use. And so a foot that is actively inflamed or is inflamed with an increase in the temperature difference, that's an active Charcot. One that the temperature difference has normalized and it's more in the latent phase, that's an inactive Charcot. But I proposed a two-axis clinical classification that was later determined to be prognostic for amputation, and that you see over here in the right. That's where we describe Charcot as either 1, 2, 3 in the forefoot, midfoot, or rear foot, going from distal to proximal, and then the stage of the Charcot, the clinical stage. So it's either acute Charcot without deformity, A, Charcot with deformity, B, Charcot with deformity and an ulcer, C, Charcot with osteomyelitis, D. And so goes from A to D as more complicated. And so as you go more proximal or more complicated down the graph, it makes sense that this is a good predictor of amputation. So let's talk first about medical managements. There are several described therapies. Offloading and immobilization by far are the best practice in Charcot treatments, but there are pharmaceuticals that have been described: bisphosphonates, intranasal calcitonin, some even newer ones now that we're thinking about using, TNF alpha inhibitors. Data's not out yet on that. Also, electrical and ultrasonic bone stimulation has been used for Charcot. So let's talk first about offloading and immobilization. I want to bring your attention to the total contact cast. The TCC is the most effective treatment for Charcot foot. It should be used during the emergent phase, even while we're undergoing the diagnostic algorithm. And it has several mechanisms of action. You can look over here on the left. The first is due to the shape of the leg, because a leg is thicker in the calf or higher up in the leg and thinner down by the ankle. It's kind of a cone. And if you think about the weight of the body pushing downward into this hard cast, it puts the weight out on the cast. And so it transfers some of the weight from the tibia to the cast. So that's number one. Number two, that helps to reduce plantar pressure because it's transferring the weight onto the actual exoskeleton of that cast. Number three, eliminates ankle motion so that there's no plantar flexion pushing down on the ground, which again reduces plantar pressures. And then four, it has less contact time on the ground because there's a shortened stride length when there's a total contact cast being used. The patients kind of limp along, and then it's also difficult to walk around in. So patients take fewer steps per day when they have a total contact cast on. So most important is to be realistic about the duration of casting. We want to let patients know that this takes between 4 and 6 months in a cast, and that should be changed every week or two at the minimum. And if we are not realistic about this and just describe to patients what's typically done in fractures, like 6 to 8 weeks, and that's the patient's expectation, that there's 6 to 8 weeks only, without understanding that this is a very long process for a complicated disease that frequently leads to amputation, then patients will be disappointed and you'll have difficulty maintaining the patient's adherence to the therapy. So there are lots of barriers to implement the total contact cast. I won't get into all of them here. I've written about them. You can look them up or email me. I'm happy to send you strategies on how to overcome the barriers to total contact cast. And you can use an off-the-shelf removable cast walker, but it is an inferior alternative, and that is because it is removable, and so we see lower adherence with, even if the offloading is equal. There are some issues with Charcot, but because of the swelling and the way that these non-custom devices are fabricated. But if the offloading was equal, there are still differences because of adherence. The pharmaceuticals, I can summarize this pretty easy. Not a lot of evidence for using pharmaceuticals in Charcot. There have been many small studies, but two important ones. The Charcot the Charcot in diabetes in the UK registry found that using anti-resorptive therapy like bisphosphonates actually increased the time to healing and return to foot wear if that was used. And then a meta-analysis was done in actually just this year, 2021, of all the RCTs for medical treatments for Charcot, and found that there was no significant difference in the time to remission till that patient got into remission versus a total contact cast alone. So in reality, the pharmaceuticals have not proven their worth yet for the Charcot foot. Surgical management, there is limited evidence, but a couple of recent papers I'll point out. The systematic review, almost 1,200 patients, found exostectomy is useful to relieve bony pressures. Achilles tendon lengthening helps to reduce forefoot and midfoot pressures. Arthrodesis is useful in patients with instability, pain, or recurrent ulcerations. Another systematic review, again, around, there's 1,100 feet. 65% of these patients underwent internal fixation, 31% external fixation, and 4% a combination. There was a bone fusion rate of 86.1%. No difference in the type of fixation. They found that the fusion rate was the same regardless of fixation used. And 91% of these patients returned to some level of ambulation, most of them probably aided ambulation. And then post-reconstruction amputation was only 5.5%. So pretty good data on Charcot foot reconstruction. And I think this is the last slide I have here, but this is just the simplified algorithm for the approach to the Charcot foot for the non-specialist. If you're a specialist, you might follow a different algorithm that we've written, and we put it into diabetes care in the consensus document, and we'll be revisiting that again next year in our new consensus document. But for the non-specialist, the important thing is to have a high index of suspicion on the clinical exam. Most important. When you do that, then you go straight to radiographs. Radiographs are either positive or negative. If the radiographs are positive, then we move straight to offloading and a specialist referral at that point. Now, let's say the radiographs are negative. Well, you know what? You go straight to offloading anyway, because that type of treatment has little risk of harm and great risk of benefit. So go straight to offloading in that case, get an MRI, and the MRI is either positive or negative. If the MRI is negative, it's not Charcot. If the MRI is positive, over to a specialist referral, and there we go from that point. So I thank you very much for your attention and the honor of being able to address you. I'm sorry, not in person, and hopefully we'll be able to do that again soon. So from the United States, Texas, thank you very much.